So good morning, and thank you to the organizers for the invitation to be here with you. I've really enjoyed the meeting over the last 24 hours. It's been a great agenda, and it's so lovely to see so many people in person, be able to catch up with some old friends, meet new friends, and learn about all of the wonderful work that colleagues involved with MASC are doing. So these are my disclosures. None of these disclosures are related to the topic I'm going to be speaking about, but rather to my role as a medical oncologist treating endocrine and GI malignancies. So over the next 20 minutes or so, what the three questions that I hope to address are, why is cancer care at home important? I think this particular group probably appreciates that well already. What are the digital health-enabled solutions to optimize cancer care in 2022 and beyond? And what are some of the key implementation barriers? So I'm not sure if anybody else has noticed, but over the last couple of years, there's been an increasing attention in the medical literature, the oncology literature specifically, around this concept of time at home for persons with cancer, or the time toxicity of the treatments that we deliver to our patients, whether that be with extra clinic visits, for intravenous infusions, or being hospitalized as a result of their treatment that they've been receiving. And perhaps this is because the pandemic has really accelerated the uptake of virtual care, has shown us some of the benefits: decreased travel time, decreased wait time in the clinics. But when I really reflected on my experience as a medical oncologist, in fact, many of our patients are already spending a lot of time at home. And one of my good colleagues and friends who spoke in the session just before this on engaging with patient partners, who is also a cancer survivor and did a time study of his own time as a cancer patient, most of our patients actually spend a very little time with providers. In his particular case, he estimated about 1%, or in fact less than 1% of his cancer journey was spent with cancer providers. Perhaps some of our patients who have advanced cancer might spend a little bit more time in the cancer centers. But in fact, home is really a big frontier where our patients don't have a lot of interactions. And in fact, I think the question is not about just maximizing time for our patients, but really about how we can actually provide better care in the environments where our patients are spending a lot of our time. And I think digital health technology can help us both maximize the time that our patients are spending at home, but also improving the quality of that time. And so I have a picture here of the desert, because I think in many ways the home frontier for our patients is really the desert. They're there on their own, managing their symptoms or managing their cancer, a lot of times with very little input from their healthcare team. So the opportunities that I wanted to discuss, and some of my other panelists will get into more details about some of the aspects of these opportunities, are remote monitoring, virtual care, and hospital at home. And we face different challenges with these three different opportunities. So this is just a brief schema of the very now famous STAR study that I'm sure Dr. Bash will be discussing in more detail. But just to remind everybody, and I'm sure everybody in this audience is very familiar with this study, but basically patients with advanced cancer were randomized to self-monitoring using an online e-tool on a weekly basis versus just standard monitoring and alerting for those that met certain thresholds. In this particular study, the intervention was associated with higher quality of life, better healthcare utilization or fewer emergency room visits, and improved survival. But the point that I wanted to make is that this is not the only study that has shown us that remote monitoring is good for patients. So another study from France, focusing on the advanced lung cancer population, has also shown improvements in quality of life and survival. And in fact, these two are not the only studies. We now have more than a half a dozen high-quality, large studies showing us that remote monitoring is good for patients, especially with respect to symptom control and quality of life. And in the two studies that have looked at survival, improved survival. So what's the issue with remote? We have evidence. Where I think we're running into problems is really in an adoption. And I think this was actually mentioned in one of the earlier sessions today, that somehow with remote monitoring, we have the evidence, yet the evidence has not made it into practice. And there are many barriers. It's a complex intervention, but these barriers are financial, so the infrastructure to actually deliver this type of remote monitoring, reimbursement models. A lot of our a lot of us practice in environments where it's fee-for-service, so who's going to reimburse this kind of care? Technology, so interoperability, data security, and I think Dr. Bash will be covering some of those aspects, but also the people piece, so the mindset. It's hard to, in the change inertia, it's really hard to change the way you do things, and this requires a kind of a flip of the way that we manage patients. I think there are some potential solutions. One that I did want to mention, which is also a digital kind of health solution, is that as we're gathering more experience and more comfort with using big data, I think the way that we can accelerate adoption of remote monitoring is by focusing on the patients who need it most. So this is a study from a institution in the US that utilized machine learning to identify patients at highest risk of toxicity using a machine learning algorithm and focus their sort of enhanced monitoring during radiation on that particular population. And they were able to show that there were fewer acute visits in this particular patient population. So I think one of the adoption strategies for us for remote monitoring is that perhaps we don't monitor everybody, but we do make sure that we monitor those patients that need it most. And there's also a number of other studies that have developed predictive models for identifying those types of patients. So switching gears a little bit, I wanted to talk about virtual care utilization. And ironically, with virtual care, we don't have a lot of evidence, but we now have a lot of adoption, partially as a natural experiment of the pandemic. And this is just a picture that shows you the just a dashboard, sort of a utilization dashboard from my own cancer center, which is about 2 kilometers up the road, Princess Margaret Cancer Center, and shows you on that since early 2020, on sort of furthest, my furthest left, I think, or right, sorry, it's flipped around. We had very little adoption or utilization of virtual care. There were just pockets. But very rapidly in March and April of 2020, the adoption shot up and has been sustained. And I think many of us have seen this in their own cancer centers. For us, that adoption has been mostly in the form of telephone-based care. We still face a lot of issues with video-based care, but both have been uptaken and are persisting. So last year, in the summer of last year, we thought, well, we're utilizing this. So what has been the experience with virtual care, both from our patient as well as a provider perspective? So last summer, we conducted a study at Princess Margaret looking at patient and provider experiences and satisfaction with virtual care. And I just wanted to share some of the experiences because I think they really reflect well on and sort of on what's been going on across the globe. So first, I wanted to comment on appropriateness. So we asked both patients and providers regarding appropriateness of care, and this is at the time when when virtual care kind of went live post-pandemic. We didn't have a lot of guidance about what was appropriate and what was not appropriate. So mostly, we were using our best clinical judgment, and what we found was that both patients and physicians agreed in general when virtual care was appropriate. So, for example, follow-up of during survivorship care. On the other hand, patients and providers agreed that there was breaking bad news or an initial consultation were likely not good scenarios where virtual care would be appropriate. Interestingly enough, for our patients, we didn't see much difference in their preferences around video versus telephone-based care, but perhaps that might be due to the fact that the majority of our patients, in fact, had telephone-based care, so perhaps didn't have the experience of video to compare it to. When we asked overall satisfaction, our patients were generally very satisfied, so 81% told us they were very satisfied or satisfied. Interestingly enough, our providers were less satisfied. Only about 53% told us that they were very satisfied or satisfied with virtual care. And one of the reasons that this might be the case is that when we asked patients and providers about whether virtual care takes away some of the human interaction that I value as part of my care or work, our patients told us 60% of them agreed with that statement strongly or very strongly or agree. However, 82% of our providers, so this is about a year after sort of this rapid adoption, told us that virtual care takes away some of that human interaction. And so that might explain some of the sort of lower satisfaction amongst our providers. We had some additional findings which I wanted to highlight for this group because I think we do need to think about this as we move forward with virtual care. One of the sort of big themes that had come out of the survey and the interviews that many of the physicians told us that that virtual care increased their workload, and whether that was related to the issue of the actual, that there were more tasks that they were doing, or perhaps the fact that they were often doing this sort of alone in their office and away from their regular team, we don't know. Many physicians felt that they were missing relevant clinical information during those visits. So what can we do to ensure that that additional information is available? And digital technology might help us with that, providing vital signs or increasing the use of video visits. As far as our patient experience is concerned, many patients were satisfied. They liked telephone. But an interesting kind of a trend that has come out, and I have seen this more even in the last year, is that many of our virtual patients have a greater expectation that the appointment is on time. So when we started with virtual care and, we were all getting adjusted, we often would provide our patients with sort of a 2-hour window, and, the doctor will call you within this 2-hour window. And I think at the beginning of the pandemic, a lot of our patients felt they were okay with that, but I'm finding, and certainly this came out of the survey and some additional patient experience data that we've been collecting, is that nowadays most of our patients are expecting that the doctor is going to call you on time, and if you haven't called them within the 10 or 15 minutes of their appointment, they're often calling the office to find out, what's happening. And that may be because when our patients are in our clinic, they can see a busy waiting room, they can ask somebody about what's going on, and whereas at home, they're just kind of sitting, waiting by the phone, and it can be very distressing. So I think we need to figure out solutions on how we can actually let them know, create virtual waiting rooms and help our patients with this particular piece. Another aspect of virtual care that I did want to highlight, we didn't have an opportunity to look at this in detail within our own data, but this has come out of several studies in the US, is this issue of equity and equity of access. So this is a study from UC San Diego who looked at about 30,000 patient encounters, probably about a third of which were virtual during the early phase of the pandemic, and they saw substantial differences in uptake of virtual care amongst certain patient populations based on their ethnicity and race, preferred language, household income, or insurance. So I think as we adopt many of these digital interventions, we have to make sure that we don't leave certain groups behind and in fact widen the gaps in care for those particular patient populations. There are other challenges, so digital health literacy in general. So one of the issues that, for example, that was highlighted in the UC San Diego study was that in order for patients to be able to have a virtual visit, they needed to have a smartphone or a tablet or access to the internet, and just sort of making their way. If someone isn't used to navigating on the internet, they might have difficulties connecting. The issue of team-based care. So in oncology, we work in teams. I work in my clinic with a nurse. We have learners in my clinic. So with virtual care, it's very hard to replicate that and replicate that effectively. And so we need to figure out those models because our patients benefit from the full team, not just the physician. The concept of learner integration. So many of our learners just had to sort of switch on a dime and start sort of practicing and learning in this environment, but there's ways to go. And this issue about quality of care. So we really don't understand what the impact has been. I think our general sense is that it has been okay, but I haven't yet seen studies fully and extensively evaluating this. And there have been some studies coming out from some other areas of medicine that have suggested that perhaps actually virtual care may lead to additional healthcare utilization, because if you speak to a patient that you should have probably seen in person, then you have to create another appointment, or perhaps you speak to them and you can't really do anything because they need additional assessment and you have to send them to the emergency department. So I think a lot of that work is ongoing and will be coming out and will inform sort of the appropriateness question. The good news is that we now are starting to get some guidance and tools as well. So I did want to highlight the ASCO standards. I think we do have our own Ontario-based guidance, and I'm sure people from other countries have their own guidance, but at least the tools are starting to emerge, but I think there's work to be done. The last piece that I wanted to highlight, and this is more of an emerging kind of theme, is that of a hospital at home. So hospital at home is defined as a model of care in which hospital level care is delivered in the home setting rather than a traditional unit. while there is some literature from even as far back as 20 years ago focusing on the hematologic transplant population and obviously the work in palliative and end-of-life care, there isn't actually a lot of literature about providing acute oncology care in the home. There was, however, a recent study that I wanted to highlight. And why is this important, first of all? I mean, we do have an epidemic of hospitalization, so there's been many studies similar to this one. So this particular study looked at 25,000 patients over a course of about, I think, 10 years in the US and diagnosed with an advanced solid tumor malignancy, and 71% of them had at least one emergency room or hospitalization. We've looked at similar data in Ontario, and even in our adjuvant patient population, 1 in 2 patients will have at least one hospitalization during the course of cancer treatment. So we have a real epidemic of hospitalization. So the one model that has been recently published is that from Dr. Mooney and her team in Utah, the Huntsman at Home program, and they've published their original experience both in JCO and in New England Journal Catalyst. So basically what they developed is starting in 2018, a program whereby some of their patients that would normally get traditionally admitted to their hospital would be able to sort of be discharged to home and be looked after in the home by nurse practitioners and nurses and a home health care agency. The particular eligibility criteria would included things like living close to the Huntsman so that if problems arose, you could quickly get back and get the right kind of care. The majority of the initial patient population that they've looked at were solid tumor malignancies, including gastrointestinal and lung cancer patients, and the types of problems that were looked after in the home, and quite successfully, as I'll show you in a second, were pain control, electrolyte imbalances, failure to thrive, and infections. And what they found is that they saw a lower rate of hospitalization and rehospitalization. So really, they sort of followed 30 days after patients were discharged from this program, or a comparative cohort that actually got in hospital care, and they saw a lower rate of rehospitalization in their cohort and lower costs. So certainly a very promising program. And I know that there are other places in the US and Australia that are experimenting with these types of programs at home, and so I look forward to seeing the results over the coming years. So what's the bottom line? So I think from remote monitoring, I think we have a lot of evidence that it improves patient and potentially system-level outcomes. I think our biggest challenge is really the adoption piece, and there are many challenges to that, including financial and change management. Some of the solutions to help us overcome the adoption issue are focusing on the high-risk population. I think that's where we're going to see the most value with these types of programs. Having novel reimbursement models, and I think there are places in the world where they're starting to explore that. And advocacy, I think, is important. And that advocacy should actually be coming from us as well as clinicians, that I think we would expect this for our patients. If this was a drug, it would be paid for and patients would already be receiving it if we saw a 5 or a 7-month survival benefit in the advanced care setting. As far as virtual care is concerned, the pandemic has really facilitated adoption, and I think it's here to stay. It is a good option for many, but not all contexts. We do need to watch this equity piece from our patient perspective, and for the providers, we do need to watch the wellness. And the plenary yesterday focused on provider wellness, and if this is going to negatively impact our provider wellness, that we need to think about that as well. There are opportunities for optimization, so I think we shouldn't look at these solutions as sort of siloed, but rather as an integration, so remote monitoring with virtual care. This concept of asynchronous model, so rather than substituting the care that we already deliver and doing it differently, but rather doing things differently altogether. So perhaps some of our patients don't even need to be seen. Maybe they have high self-management capacity, they're doing well, they'll have some tests, they'll review the test, you review the test, and you actually agree that maybe this patient doesn't even need to be seen. And some of my urology colleagues are exploring some of these options. But we do need an evaluation framework and some metrics so that we're all speaking the same language when we're evaluating virtual care going forward. And last but certainly not least is the hospital at home. I think the timing is right because of the sort of growing epidemic of hospitalization and the growing demands for oncology care within our constrained systems. I don't know about your centers, but our centers almost every day on what we call level 4, which means that patients are sort of spending at least first few days of their admission in the emergency department because we don't have enough beds. And also our remote monitoring capabilities have improved, so our ability to look after patients at home is a lot better. I didn't even mention any things like measuring oxygen saturation or continuous vital signs monitoring, but that work is also being explored. The preliminary results are encouraging, but it's really from only one program so far. So I don't think we're kind of ready for widespread adoption, but we are ready for experimentation. So I look forward to hearing more about that. And we'll need to sort out the optimal model components. So, who are the right patients, what kind of providers, what kind of care, et cetera. So I think we are at a time where there are some exciting opportunities to improve cancer care at home with technology. This will improve in maximizing the time at home for our patients, improve patient outcomes, and improve system-level outcomes. But there are some real challenges to wide-scale adoption and sustainability, and we require a deliberate and coordinated approach. So I think I see this as a call to action, and depending on what role you have, and many of us have multiple roles, the call to action is different. So for the researchers in the audience, I think there's still evidence generation, there's evidence gaps that we need additional information, whether that be of benefit, so for example, for the hospital at home, or on implementation approaches. And I think implementation, we need to be thinking about implementation right from the beginning, not sort of as an afterthought after we showed that the model is potentially beneficial. And there's still opportunities to innovate beyond that. I think, we've already changed the way we do things in medicine. I mean, what I've trained to do 20 years ago in my medical oncology residency to how I practice now has changed quite a bit. So I think there is opportunity for innovation beyond the things that I've discussed this morning. For our clinicians, they need to change their mindset that we need to do things differently. It can't just be focused on those clinic visits every 3 weeks or 4 weeks or whatever time that we see them, that we really need to be looking after our patients the whole time, perhaps not the individual clinician, but as a team, and how do we do this effectively? We need to have our clinical colleagues participate in some of this research. I see a few of my colleagues in the audience that run a lot of these studies. It's sometimes hard to get our busy clinicians to sort of say yes and then consent and bring on patients and be research subjects themselves. And then we need to advocate to our policymakers and our leaders that we want this for our patients, that this is good for our patients. In terms of our policymakers, they need to change their sort of mindset. Sometimes some of these interventions really, it takes time to see the full value. There's sort of an upfront investment and the value is downstream. And so they need to have the courage to take sort of the leap, the upfront investment to see the long-term benefits. So I'll end with that, and I'm hoping that we'll turn this desert at home into an oasis. Thank you very much.